This module will cover the screening and care of non-communicable diseases in children and adults presenting with HIV. This module, you would be able to understand, identify, screen, and manage the common non-communicable diseases in people living with HIV and also in children living with HIV. And you would be able to implement the WHO PAN package of non-communicable diseases, and you would be able to implement the different components of care for children with HIV, which has already been discussed in our consolidated guidelines. Our learning objectives. The presentation will be covering the disease but screening and benefit of NCDs in adults. Then we will discuss about the PAN package. And then we will discuss the screening and management of NCDs in children living with HIV, routine care, and the specific diseases, especially thalassemia and neurocognitive disorders, their management and monitoring, and then the components of care package will also be discussed. So, what is, by definition, the non-communicable diseases are? WHO defines a non-communicable disease as an illness which is not caused by an infectious agent and could not be transmitted from person to person. The examples include diabetes mellitus, hypertension, osteoarthritis, and other diseases which are non-infectious. 15 million people between 30 to 69 years die of these non-communicable diseases every year. In low and middle income countries like Pakistan, 85% of premature deaths occur due to these NCDs. While talking about children and adults, they are all with HIV, they are at increased risk of non-communicable diseases. The studies report that regardless of their ART status, 40 to 70% risk increases of MI and cerebrovascular accidents in these patients. Studies report that up to 22% of patients with HIV, at least one NCD was found. Among mental health disorders, 36% had depressive disorders when the study conducted in Africa. Study conducted by Kansemi et al. Concludes that the most common NCD in these patients was found to be hypertension, followed by osteoporosis, diabetes mellitus, renal impairment, asthma, cardiomyopathy, and other had lesser frequency. Higher prevalence in older participants, widowed participants, and patients with opportunistic infections. Different studies report the incidence higher in men as compared to the women, and in a study conducted in key population reports that 92% of the key population had cardiovascular disease and hypertension as non-communicable disease. Meta-analysis also suggests that hypertension was the most common non-communicable disease among the people living with HIV. Vascular accidents increases due to HIV-related chronic inflammation, immune reactivation, drug-drug interaction, their lifestyle, and the elevated burden of known cardiovascular risk like a general population. And there are certain ARTs which affect on lipid profile and other cardiac parameters and can contribute to these cardiovascular diseases. For example, protease inhibitors are associated with dyslipidemias. Abacavir has been shown to increase relative risk of cardiovascular diseases. Lopinavir, ritonavir boosted have effects on QT prolongation and can cause conduction-related abnormalities. So all these factors are contributing to the increased risk of myocardial infarction and cerebrovascular accidents. Every visit is screened for hypertension. If your patient is not already known for hypertension, you have to take the history and monitor their blood pressure. If your patient is already known to have hypertension, assess the control of hypertension on current medication and their compliance with medications, and screen the patient for ischemic heart diseases through history. Also inquire about the risk factors which are known to cause the ischemic heart diseases and poor control of hypertension, like smoking, tobacco usage, and their lifestyle habits. And also if a patient who's already controlled blood pressure and now his blood pressure is uncontrolled, assess for drug-drug interactions. Now, in every visit, you have to counsel the patients about quitting smoking, tobacco consumption, and encourage them for improve their physical activities. If with these interventions, the pressures remain uncontrolled, then you have to refer this patient to their specialist. Also, assess the 10-year cardiovascular risk. If it is found to be more than 20%, then refer this patient to the specialist for antiplatelet therapy, lipid lowering, and adjustment of antihypertensives. Like hypertension, also assess the patient for diabetes mellitus control and compliance with medication. So his or she is already known to have this disease, and if in control, refer to the specialist. And if patient is not known for diabetes mellitus, then assess the risk factors and screen for diabetes mellitus. If has introduced, WHO has introduced an excellent uh, package of intervention, which is known as PEN, or Package of Essential Non-Communicable Diseases Interventions. This package mainly focuses on the assessment and management of the diseases which increases the cardiovascular risk. These include high blood pressure, type 2 diabetes mellitus, chronic respiratory diseases like asthma and COPD. Not only this package also helps in early identification of breast and cervical cancers. So you can go to the website and download this app in your laptop. You have two options to download this app. Number one, you can download it on your laptop through web version, and you can see the diseases have been listed here are cardiovascular, diabetes, respiratory diseases, etc. And it has given the cardiovascular risk assessment calculator as well. So you can assess the 10-year cardiovascular risk. And you can also download it from the Google app in your mobile. And this is how it looks like on a mobile. So you can efficiently manage this patient presenting with non-communicable diseases in your OPDs through the help of this PEN intervention package. Children living with HIV are also at increased risk of developing non-communicable diseases. Malnutrition is more common. The factors which make a child vulnerable to develop these diseases include prematurity, history of recurrent severe pneumonias, dry diseases, exposure to tuberculosis, suboptimal breastfeeding and nutritional deficiencies, which leads to the poor growth. Mother or father who are already having HIV have compromised health status, both physical and mental, and they may not take care of their child the way they are supposed to. So this also contributes in compromised health of a child. Then isolation, marginalization, and lack of interaction with community, poverty, exposure to violence, and exposure to maternal HIV and ARV medications all contribute to make a child vulnerable for this disease. Low developmental delay and neurocognitive impairment, mental health disorders, chronic lung disease, kidney disease, heart disease, and this is more common in adolescents who acquired HIV perinatally. All children at each visit should undergo clinical staging of HIV along with TB screening using PPA score. ART should preferably be deferred for children with PPA score for more than 7, and ATT should be started. For PPA score less than 5, ART can be started and child should be followed regularly. If available, a CD4 count should be done at first visit to assess the level of immune suppression. Decisions on need for prophylaxis can be made during these visits based on clinical and CD4 staging. General care of a child living with HIV includes vaccination, monitoring of adherence to the ARVs, diagnosis and management of common and uncommon HIV-related illnesses, which include impetigo, fungal type dermatitis, recurrent thrush, recurrent infections, seasonal diarrhea, etc. And the workup should be sent if indicated and wherever possible. The child should be encouraged to join school, and socialization of children should be encouraged. Malnutrition is a big problem in Pakistan. It contributes to the mortality not in general population but also in HIV infected patients. Malnutrition by definition. So, malnutrition is a condition that develops when the body is deprived of vitamins, minerals, and other nutrients it needs to maintain healthy tissues and organ function. In HIV infected children, wasting, that is, low weight for height and length, has been associated with reduce duration of survival, while weight loss increases the risk of infectious complications, especially in children living with HIV. The nutritional assessment of correct nutritional status, diet, and nutrition-related symptoms is critical in early identification of malnourishment and poor growth, and for monitoring of HIV disease progression and treatment efficacy for children who are on ART. The nutritional assessment should be the part of routine clinical monitoring of HIV-infected children, whether or not they are receiving ART. Who are suffering from HIV, we have two options for feeding. Number one is exclusive breastfeeding, and number two is breast milk substitute. The exclusive breastfeeding is preferred and encouraged, especially during the initial 6 months, unless the breast milk substitute is acceptable, feasible, affordable, sustainable, and safe. Only then the child should be shifted to breast milk substitute. In a child who is not receiving exclusive breastfeeding, the risk of infections and dehydration increases. The commercial formula is preferred over home modified animal milk, and this milk is generally not recommended in first 6 months. Cup and spoon method is better than the bottle feeding and is recommended. A child should be measured monthly for growth, just like a general population, and you can find the growth charts on the link given in the presentation. Full nutritional assessment should be done at every 3 months. If a child is in any other age, the energy requirement varies with the stage of HIV. In an asymptomatic child, the energy requirement is increased by 10%, hence it is recommended to increase the energy intake by 10% of RDA. This energy requirement may reach up to 100% in an advanced HIV. If a child is symptomatic or recovering from acute infection, this energy expenditure may rise up to 20 to 30%, as it is recommended to replace this 20 to 30% of RDA. The micronutrient replacement has not been included as a firm recommendation. However, different studies have shown that this may help in improving the mortality and morbidity in different conditions. Example, vitamin A has shown to reduce the all-cause mortality and has shown improvement in growth when given to the malnourished children. Similarly, zinc, when given in acute diarrheal illnesses, has shown to reduce the morbidity. Vitamin D, when given to the poorly nourished children in sub-Saharan African countries, has shown the reduced duration of all hospital admissions. Along with this micronutrient replacement and energy expenditures, another more important thing which should be taken in consideration is infection control practices compliance. Mothers should be told to maintain self-hygiene and should wash hands before making the food or before handling the food or milk of a child and after using the washroom, and she should use clean water to prepare the food. The child should be assessed for malnutrition status on regular basis, just like a general population, and the malnutrition should be, if present, should be categorized as severe, moderate, or mild. The VAS score can be used for nutritional assessment. IMCI guidelines can be helpful to assess the different illnesses in a child and should be used, and child should be managed according to these guidelines. The following links can be used to assess the growth with the help of growth charts available, and the nutritional assessments can be solved from these links. For children under 5 years of age presenting with acute malnutrition, the first step is to categorize this malnutrition as mild, moderate, or severe. For this categorization, 3 things should be considered. Number 1 is VAS score. This is weight for age C score. Then the medical conditions, and then the systemic signs and symptoms present in a child. If VAS score falls between -2 to -1 is standard deviation and there is no edema, child is clinically stable, eating well, counsel this child for supplementary feeding with vitamin D and iron and advise deworming and send home. Once the score is below -3 standard deviation, look for associated medical conditions. If the associated medical conditions are mild or minimal, for example, there's a pitting edema, but it's mild. Child is feeding well and having good appetite and clinically well or having mild infection. The child can be referred to nutrition support program to be managed as an outpatient. But if the medical conditions are moderate or severe, for example, he is having bilateral pedal edema, pitting edema with any of the following, and includes severe wasting, high or low body temperature, acute or prolonged respiratory infection, watery diarrhea with or without vomiting, and poor feeding, poor appetite, extensive oral thrush. This patient should be referred for nutritional support program and should be managed as an inpatient. Section, we shall be discussing specific diseases and associated infections. With these non-communicable diseases, briefly we shall discuss about thalassemia and neurodevelopmental disease. For detailed knowledge, you can refer to the updated Pakistani guidelines on HIV. Beta thalassemia are the group of hemoglobinopathies divided into thalassemia minor, intermediate, major, and hydrospitalis. Patients with beta thalassemia major present with the signs and symptoms of chronic anemia, may present in anemic failure and hepatosplenomegaly and bone changes. In Pakistan, the bone marrow transplantation is not very commonly available, hence the mainstay of treatment is regular transfusions. HIV in this population is majorly acquired due to these transfusions. The prevalence of thalassemia in HIV has been recorded more than 20% worldwide. However, the statistics are not well recorded in Pakistan. It is important to know the thalassemia status because the choice of ARV is very difficult and we have to modify sometimes the ARVs due to the presence of anemia, liver and renal diseases. There are certain issues which are related with the thalassemia management. Number one is the issues which are related due to transfusions, and these are iron overload, hyperlipidemia, and transmission of blood-borne pathogens. The iron overload may cause an organ dysfunction and multiple endocrine pathologies, along with cardiac and lung dysfunctions and chronic pain. Hyperinsulinism may result in early cystitis, abdominal fullness, and pancytopenia. And then the transmission of bloodborne pathogens results in acquiring different infections. Whenever a thalassemia patient is registered in your ART center, you always try to connect them with the thalassemia center for better management, for regular transfusions, and chelation therapies. Then there are the issues related with chelation therapies, and vigilant monitoring is required to look for these and to pick these side effects early. There are some certain infectious etiologies associated with the management of thalassemia. If a patient has undergone a splenectomy, the risk of overwhelming sepsis due to some capsular bacteria is increased. Not only the capsular bacteria, but many gram-negative organisms and protozoa like malaria, babesia can put the life of a patient in danger due to overwhelming sepsis. The therapy associated with iron overload and chelation invites the iron-loving bacteria like Yersinia enterocolitica. The patient presents with acute abdomen, and there are many other organisms including Listeria and Legionella and Pseudomonas aeruginosa, which have been shown to have increased virulence in the presence of excess iron. Liver and gallbladder are also affected in thalassemia patients, and this can be multifactorial. For example, the infections which can be transmitted through transmissions hepatitis B and C, and iron overload, the side effects of medications, and other liver diseases. Patients with thalassemia should be monitored clinically on every visit and with LFTs for every 3 months, and if status of hepatitis B and C should be checked yearly if the patients are negative, and if patient is vaccinated for hepatitis B, then the titers should be checked regularly. Before proceeding for hysterectomy, all routine vaccinations and important vaccinations should be done. Chelation therapy should be considered in the specialized units. And the management of HIV in such patients should be done in liaison with an ID expert, hematologist, hepatologist, cardiologist, endocrinologist, psychologist, and genetic counselor if available in your region, social workers, and dietitian, because the management of HIV in these patients is very complex and should be done with multidisciplinary team. Patients with thalassemia should be monitored clinically on every visit and with LFTs for every 3 months, and if status of hepatitis B and C should be checked yearly if the patients are negative, and if patient is vaccinated for hepatitis B, then the titers should be checked regularly. Before proceeding for hysterectomy, all routine vaccinations and important vaccinations should be done. Chelation therapy should be considered in the specialized units. And the management of HIV in such patients should be done in liaison with an ID expert, hematologist, hepatologist, cardiologist, endocrinologist, psychologist, and genetic counselor if available in your region, social workers, and dietitian, because the management of HIV in these patients is very complex and should be done with multidisciplinary team. Is another problem in children living with HIV, which can be easily missed if not properly looked for. The causes are multifactorial and include ongoing viral replication, irreversible CNS injury before initiation of ART, neurotoxic effects of ART, and these are compounded by socioeconomic and psychosocial factors. The diseases included in this umbrella include dementia, attention deficit hyperkinetic disorders, depression, etc. The disease is especially common in those who are diagnosed within first 2 years of life, and they may be presenting with developmentally delayed or slow motor and cognitive milestones. Monitoring of a child should be done at the baseline, and motor and cognitive functions must be assessed, especially at 3 months, 6 months, 9 months, and 18 months, and appropriate reference should be made if indicated. Are also associated with HIV. The overall incidence of cancer was found to be 82 per 100,000 person years in South Africa in children. The most common cancers found in children, Kaposi, sarcoma, and non-Hodgkin's lymphoma. The study done in United States of America has shown the decline incidence of Kaposi, sarcoma, and non-Hodgkin's lymphoma after initiation of ART, but the risk of developing non-AIDS defining cancer did not fall with this ART, and hence continued monitoring for these cancers is indicated in patients even if they are on ART. Can be managed with the help of IMCI guidelines, which have been developed by WHO and UNICEF to deal with these illnesses, and the other common illnesses like typhoid, dengue, and malaria, and COVID should be managed these are managed in non-infected, non-HIV infected population. So there are no separate guidelines for the management of these. Comprehensive care package for infants and young children to minimize the risk of exposure through vertical transmission and improve the health and well-being of infants and young children who have been exposed to HIV. The components include the maternal testing, retesting, maternal ART initiation, adherence, counseling, and monitoring. And then infant-based components include infant diagnosis, ARV prophylaxis, CPT prophylaxis, postnatal care, and infant feeding, and promoting nurturing care. The components have been described in different modules under relevant sections. Nurturing care includes adequate and quality HIV prevention and care, provision of nutrition, ensuring security and safety, responsive caregiving and opportunities for early learning, and it has shown direct effects on child development. The discussion of this is beyond the scope of this presentation and can be found on website. The take-home message of this presentation, we should always remember that the risk of non-communicable diseases is higher in people living with HIV and children living with HIV. The most common non-communicable disease is hypertension in adults. Multiple factors play a role in increasing the risk of non-communicable diseases, and this include chronic inflammation, drug-drug interaction, lifestyle modification, and immune activation. The screening for hypertension, ischemic heart disease, and mental health should be done on every visit. If an uncontrolled hypertension or 10-year cardiovascular risk is more than 20%, refer this patient to the specialist. Lifestyle modification should be advised to every patient. Children living with HIV have increased risk of neuropsychiatric disorders, and screening should be done as per guidelines. Component of care include journal care, growth monitoring, nutrition assessment, feeding, immunological monitoring, and mental health assessment. Children living with HIV with severe malnutrition should be referred for nutritional support. Feeding for infants is indicated for initial 6 months until the substitute is FR. Nutritional assessment of children should be done like as a general population. Non-communicable diseases like thalassemia should be managed as per guidelines. The management needs multidisciplinary approach. Screening of HIV for chronic lung diseases and cancer should be done. WHO has designed PAN package for dealing with non-communicable diseases. The complete package of care has been introduced by WHO, which includes maternal HIV testing, retesting, ART, adherence, counseling, and monitoring, infant diagnosis, ARV prophylaxis, CPT prophylaxis, INH prophylaxis, postnatal care, and infant feeding in the context of HIV and promoting nurturing care. Thank you so much.